So the idea itself, like there is a preparatory class before the exams. Because when we were undergraduates, then there were no such programs. So we were really blessed. So today's class is about short stature and approach to short stature. So we will discuss some ideas about short stature. I will be using a slide set, but we will deviate from it as and when needed. Everyone is, we can be a little interactive also. Okay, because this is a classroom. So, and don't hesitate to answer. You can give wrong answers. That is why you are students. Okay, you can give wrong answers, no problem. So, can anybody tell me what is short stature? What do you mean by short stature? Yes, one of you, please. Good. Yes. Tell me a wrong answer, that's all. Yes. Less than? -2 standard deviation in the growth chart. Isn't it? Yes, you are right. So, when you are using a growth chart, when someone is below the third percentile means what? The lowest line, the lowermost line in the growth chart. That means you are short. So, like that, there are some expectations about the height. Okay. So, someone says that less than 150 centimeter height is called a short stature. Okay. Actually, for disability purposes, you may have heard of disability, isn't it? Disability. So, disability board certification for short stature, their cutoff is 145 centimeter. If an adult is less than 145 centimeter, they get a disability certificate. Like that, there are different types of definitions. Okay. So, is short stature a medical problem? Is short stature a medical problem? This child was brought with a short stature. Okay, so the mother was telling, my child is not growing well and is shortest in the class. Is this a disease? Yes or no? No, I am happy because I was the shortest in my class. Okay, so the being short is not a disease, but when someone is short, that could be the manifestation of an underlying disease. That is why, as doctors, we are interested in a growth problem. Okay, when a child is short, we need to find out the reason because that would be a sign of an underlying disorder, underlying disease. Okay, that is one reason. There is one more reason why, as doctors, we should be interested in the growth of children. Okay, and that is yourself. How much did you grow in the last year? Huh? Did you grow? No grow. Okay, so you cannot grow. So growth is something unique to children. So if they are not provided the opportunity or the help during that particular age, then children cannot grow to their optimal age. Okay, so when does children stop growing? When does children stop growing? At what age? Any idea? No group answers. Yes. Huh? Gender. Okay, so boy. Huh? 21? What did you say? 21. No, you can say wrong answers, no problem. 21. Okay. Any other answer? Anybody? 0. Okay. So as doctors, you should all know that significant amount of growth is finished in a girl by the age she is 14 years. Okay. And significant amount of growth is finished in a boy by the age of 16 years. Okay, don't think that children will grow up to 21 years. Maybe after 14 years, she may grow another 3 centimeters or 4 centimeters over the next 4 or 5 years. That is all. So, the most important period in growth is, which is the most important period? When does a child grows the maximum? Any other answer? Huh? No, I don't agree with puberty. You tell another answer. First year of life. First year of life. Okay. So, first year of life and then puberty. These are the two time zones where children grow the maximum. Okay. Because madam may be telling you about the first 1,000 days again and again and again. Like, you are all familiar with those 1,000 days concept.
Yes,
in growth. Because madam only taught all of us. That is why I said. And regarding growth also, these first 1,000 days, you should all calculate how much growth is occurring in the first 1,000 days. You will be amazed because everything starts from a fertilized egg. So we measure it micrometers. Okay. From that, at the end of pregnancy, it becomes how many centimeters? 50 centimeters. See, that much growth is not occurring any time after birth. Okay, weight also becomes 3 kg from a few microns. Okay, so maximum growth is actually occurring before, as pediatricians we are seeing in it. That is why we are also interested in the antenatal period. You may be seeing ma'am teaching the antenatal mothers and telling about care of pregnancy. So it is very important. Then comes the first year of life. During the first year of life, how much growth occurs? 25 centimeters. That is 50 centimeters becomes 75 centimeters. Okay, this 1.5 times. That much growth is never ever not going to occur. Okay, and that is why feeding during the first year of life is the most important thing regarding growth. Because if you are losing that particular 25 centimeters, okay, you are going to lose a significant amount in your stature that is not going to come again. Okay, that is why the first year is important. So, in the first year, if it is 25 centimeters, what is the growth in the second year? 12.5, half of it. So, the velocity was something like a rocket inside the womb. Okay, it is like a racing car, maybe in the first year of life. Then it slowly comes down, 12.5. And after 2 years, you learn a formula. What is that formula? 6x plus 7 is 7. Do you learn that?
Rule of half.
Your rule of?
Rule of
half. Okay. So we are familiar with this rule 6x plus 7 is 7? Yes. But remember, that is just a formula. It doesn't have much relevance. Why? Because we know every year children grows differently. It is not 6 centimeters from 2 years to 12 years. We were not taught like that, but later we have admitted it is not that. Okay, because it is 25 centimeter, then 12.5 centimeter. In the third year, it cannot be 6. In the third year, it will be somewhere around 9 centimeters. Or some children may be 10, some may be 8.5. In the fourth year, it could be 7, maybe, or 7.5. Slowly, there is a deceleration in the growth velocity from 25, and it may reach down till it may be somewhere like 4.5 centimeters. Just before what? Just before the next growth spurt, which is called a puberty. Okay. So till then slowly the velocity comes down and then you get a growth spurt. And during the adolescence or during the puberty, children may grow even up to 12 centimeters. Some may grow 10 centimeters. Some may grow even 13 centimeters in a year. And that happens for maybe 1 year, 2 years, 2.5 years. It depends upon how fast, what is the tempo and the pace of the. And after that, what happens? Or we will first learn why this growth spurt occur during puberty. So we know during the first year of life, the breastfeeding is there. So breastfeeding is a great stimulation for growth, which the child grows and all. But during puberty, what is happening? Why the child is becoming taller very fast? Anyone? Yes? Androgens. So he is telling it is androgens. Okay, your name? Vivian told it is androgens. What do you say? Yes? Yeah, is giving a clue. So, all of you will remember a time in your school where girls were taller. Do you remember? Yes or no? See, all girls are smiling. Because there was such a time when all girls were taller and boys were short. Okay. Isn't it? Okay, so why did girls start growing early? The growth spurt is earlier in them. Why? He told the androgens. Estrogen. Yes. So actually, the growth hormone during puberty is estrogen, and girls produce estrogen from the ovaries. So what happens? They produce estrogen, and the estrogen will cause the growth of the bones, as well as the fusion of the epiphysis. That is the problem. You should change the action of estrogen. So it not only produces growth, it also produces the fusion of the epiphysis. That is why they stop growing also after some. Okay. What happens in boys? They produce estrogen? Yes or no? No. What is being produced in the testes? What is being produced in the testes? Testosterone. So when they produce testosterone and when the level is slowly increasing, a part of testosterone will get converted to estrogen. Okay, because in the fat cells we have an enzyme called aromatase enzyme. You may have studied it histology. Okay, so that enzyme converts it to estrogen, and then that estrogen actually helps the boys to grow. So boys grow because of the female hormone. Okay. And why they end up taller? Because during the growth spurt, when the girls are having growth spurt, boys didn't have growth spurt, but they are growing slowly in the normal range. Okay, and their spurt starts from a higher number. They start their spurt from a higher platform, and they don't produce so much of estrogen, so their fusion of bones also get delayed. So they end up taller. Okay, but don't worry, it is because of estrogen. Okay, that is it. So that is why boys end up taller. Okay, so this child was brought with these complaints. So we told that shortest in class is not a concern all the time, but it could be.
Somebody should be short, no?
Yeah, definitely. There are shortest all the time. And regarding this concern of not growing well, usually as pediatricians we are all very familiar with mothers who take very chubby children, hefty children to us, and the mother will say, my child is not eating. So the concern of the mother, we should give a ear, but we should see it more properly. So this particular child, the mother told his breasts are not getting small. Is that important? Very important. Very important. His teeth are not falling at normal age. That is also important. And the most striking feature is he is now shorter than her younger sister. That means there is a problem. Okay. So when a child is, what I wanted to tell you, or what I want you to understand is, when a short child is brought to us, because the first thing you have to do is not sending a blood test and not even starting to put it in a growth chart. you should ask some questions to him. So these are a few questions you should ask. Okay, are the dresses becoming shorter, or is the shoes, the child is using the shoe which he was using 3 years back, now also. That means the child is not growing. Okay, so all those questions you should ask.
Any diagnosis for this child? Lot of clues are there for the diagnosis.
Differential type, you can say differential. Yes? It could be hypothyroidism. Okay, what else? Okay, I see. Okay, so these are the growth rules, okay, which we learn. But growth rules may not be true always because each child grows in a separate line. Okay. So these are some instruments which we should be very familiar with. Okay. I think all of you are well versed using these instruments. Yes or no? Yes or no? Okay. So the thing is, you have to use an instrument with a digital. So you should not use other what you use for measuring with some other things. Okay. It should be a digital one, and the accuracy should be 10 grams for newborns, for younger babies, and 100 grams for older children. It is very important. And you should know there are machines which have tearing facility. Tearing facility. Anybody know what is tearing facility? So I will tell you. Like when you go to the vegetable shop, what happens is usually they place a container first. Okay. And then they press a key. Then it becomes zero. Then they put everything. Like that, the facility is there in many of the English. We have to find it. Okay. So, if a child is not standing, if a child is very fussy, what you can do is we can ask the mother to be in the weighing machine first. These are actually tips for exam. At the exam time, it will be very difficult. The child won't claim your your weighing machine. Okay. So you weigh the mother and child together, and then you can actually, if you use the pair, then you can actually get the weight of the child. This is called a double weight. Okay. And these are some growth rules again. At birth it is 3 kg, double square 5 months, 3 times per 1 year, and 10 times per 10. And this is the growth in the newborn. This also, I think, sometimes examiners will ask how much the newborn baby grows in a day. This is important in assessing the adequacy of breastfeeding, isn't it? We actually, when a mother is telling that the breast milk is not enough, we ask them a few questions and we measure the baby also. We measure the weight of the baby. And if you are getting enough weight gain, that is 30 grams per day in the first 3 months, then we tell the mother that there is enough breast milk. Okay, so that is important. Then, which are these instruments? Stadiometer and infant. Stadiometer and infant. Okay. All of you have used both? Which one we have used less? Infantometer. I am sure. Because using an infantometer is very difficult. Okay. Stadiometer is very easy because you ask the child to stay there, you can just bring it down. For the infantometer, always make sure the headboard is touching the head. Okay, headboard is touching the head. Then you have to keep the knee straight, and also the angle should be at 90 degree touching the foot. Okay, how many people you need to do a measurement? At least 2. Right. So actually you need 3, but at least 2 people should do. If someone is telling me, I have examined the leg without any help, then I will not accept the leg, because that will be wrong. You cannot do that. Okay, you should get help. So if there is no other person to help, you can even get the help of the bystander. That is it. But there should be at least 2. Okay, so that is very, very important. I have drawn one line. What is this line? Frankfurt line. So it joins the external PAEDIATRICS to the orbit, isn't it? Low order of the orbit. Okay, so that plane should be parallel to the ground. That means the child will be staying like this, all those things can happen. Why we are very much concerned about this posture? I told you have to keep the knees straight. Why? Because when you look at children, the older children, they grow actually, we discussed that 6 centimeters in a year. 6 centimeters in a year means in 1 month, what is the growth? 0.5 centimeter. Okay, so if your measurement is not accurate, there is no use of measure. Okay, and when you are measuring, how many times you have to measure when you are measuring the length? How many times you will measure? At least 2 times. At least 2 times. The thing is, if you measure once and when you repeat it, both are you are getting the same value. That means it is correct. You are correct. But you are getting different values. You should do it once more. Then at least one of the 2 of the 3 will be congruent. Okay, then you can identify the correct measure. These are again normal values that we already discussed. Have you had a upper segment lower segment ratio? Okay. So how to measure the upper segment lower segment ratio is important. You ask the child to stand as if you are going to measure the height. Then you palpate the upper border of the pubic bone. Upper border of the pubic bone. From there you measure till the floor. That is the lower segment. So height minus lower segment, you get the upper segment. Okay, and then you put it in the ratio. Okay, and you know there are some changes which are happening according to the age. And when the upper segment is short, okay, upper segment is short. What is the problem? Where is the problem? The problem is in the spine. This is the vertebral column. Okay, so you should learn 1 or 2 examples for upper segment shortening. Tell me. Mucopolysaccharidosis, where spinal abnormalities are there. Mucopolysaccharidosis there. Anything more? Spondyloepiphyseal dysplasias. Okay, so that means there is something happening in the upper segment. Lower segment means most, madam, hypothyroidism. Actually, hypothyroidism can present in different ways. The normal hypothyroidism will be usually proportional. But if there is a child who is not treated for a long time, there can be vertebral affection and the upper segment can be short. So if it is long standard untreated, it can be. For lower segment, which is the most common, rickets, then achondroplasia. That's enough. 2 or 3, you can just do. Okay, so this is the normal increment in length. Actually, I have written height. Actually, we should say length. Length up to which year? 2 years. Up to 2 years, we say length, and after that, we say height. Okay. Midterm circumference, I think all of you know how to do it, okay, because it is a very important OSCE station, and it is always better when you do this, you just give a commentary that you tell, I am palpating the acromion. Okay, when the examiner is hearing, I am palpating the acromion, even if your finger is somewhere else, the examiner will think you know it. Okay, and then I am palpating the auricular node. I am finding the midpoint. Okay, like that you can say.
Spot what is wrong in this?
Right side.
Right side.
Right.
Very good.
It should be the left side.
It's the left side.
Okay. But the dictum is, for example, always in the left side. And what is wrong here? They are tightened. It should be snugly. It should be snug. So I think this step is very, very familiar to all of you.
The other one is when you are taking measurement, limb should be parallel.
Right. Yes. That is when you are palpating the bony points, it should be at 90 degree. Elbow should be at 90 degree. But when you are measuring, the hand should be hanging by the side, because otherwise the prominence of the muscle will affect your measurement. Okay. What about head circumference? This is another station. Okay. So here also you have to actually do a crossover type method. That is very, very important. You have to palpate. Here also you can say I am palpating the occipital protuberance, I am palpating the orbital ridges, and then do it. So it is called OFC. And then 2 examples for microcephaly. Microcephaly, 2 examples. Examples. Torch infection, very good. Then one more. That is one of the causes.
Any syndrome?
Any syndrome. One common syndrome. Madam always teaches us, if someone asks any syndrome, we say Down syndrome. Because it could be cut. Here also Down syndrome is cut. Okay. So you can remember that. Then what about macrocephaly? Hydrocephalus, okay, then anencephaly will be small now. Hydranencephaly, okay. Both are related. Some more. Okay, so you will make a list and give it to Vijay Master, right? At least five examples, because it's very important. Right. So I am just keeping this. Okay. So here what I have done is I have put the height and weight of that particular child whom we have seen in a growth chart. I think everybody is familiar with the growth chart. Everyone know how to measure. Isn't it? So the important things are, in every growth chart there should be the name of the child. Okay. And always choose boys chart for the boy and girls chart for the girl. So when it is colored, it is easy, but if you are taking photocopies, you should actually see whether it is boys or girls. Okay. Then, when you are calculating the age, you should never ask the mother what is the age. Okay. What should you ask? What is the date of birth? Because if I am asked what is the age, my birthday is next month, I will say 1 year less. I am also happy. Okay. So that will be there, the mother will be reporting. And what you will do the measurement. See, example, 5 year, 11-month-old child is brought in. Okay, what is the age? Mother is telling 5 years. Where will be brought in? At 5 years. The next month mother is coming and telling, what is the age? 6 years. Where will you brought in? 6 years. So what is the growth during the 1 year? There is no growth. So you count a case of short stature and you will bring the child in. Okay, so that should never happen. Always ask the date of birth. You calculate the age in years and completed months and then record. Okay, and when you are recording, actually, okay, so I will just show you. Like, see, there are 1, 2, 3, 4. Okay. So this is 3 months, 6 months, 9 months and 12 months. So it is very easy. So even a single month discrepancy you can mark it. Okay. So between 3 months it is 45 days. Like that you can mark. So this child was actually, I told you, what was the age of the child? 7-year-old child. It should be only a dot. Because growth chart is a continuation of dots. Then it is a line. Okay, so that should not be the same. So from there, what I have done is I have calculated the height age. Okay, usually what we do is we use some formulas and calculate it. See, you are familiar with it. But height age can be very easily calculated using the growth chart. How do you do that? Is you just draw a line, horizontal line, towards the 50th centimeter. 50th centimeter. you can see that there is a third sentence. Third sentence is the red line. Everybody is following me? Marking doubt or not? Okay. So the red line is the third sentence. Then you have 10th, 25th, 50th, 75, 98 and 97. Okay. So there are 7 lines. The 50th sentence line is the 4th line. Clear? Clear? From top or from bottom, this is the 4th line. Okay. So never try to trace the line from 18 years. When you are tracing the line from 18 years, what will happen? It will change. See, when you are looking at that line and taking your eyes down and down, you will be going through some other line. Okay, so there is no need of doing that. It is very easy. You can just count from here. See, when you are drawing, you count 1, 2, 3, 4. Clear? When you are drawing that horizontal line, you are crossing the first line, second line, third line, fourth line. Fourth line is the which one? Okay. So you will very easily get the height. From that 50th sentence, you are just dropping your vertical and you get the height. Clear? Any doubt? So the doubt you can ask. Okay. And for weightage also the same. You are drawing it towards the 50th sentence line and dropping your vertical, you get the weightage. So for this child, the height is 3 years and weight is 6 years. Okay. So height is 3 years, weightage 6 years means what? The child is actually 7 years. A 7-year-old child is having the height of only a 3-year-old child and weight of a 6-year-old child. That means the child is poor both in height and weight, but more affected is height. So when there is a child who is not growing well and height is more affected, there are 2 reasons. One is either it is an endocrine condition, there is a hormone problem, or it could be a syndrome. Okay, syndrome means it could be a Down syndrome, it could be a Prader-Willi syndrome, any syndrome where there is short stature, or it could be a skeletal dysplasia. There are a lot of skeletal dysplasia syndromes, like you told about achondroplasia, all those things. Okay, that weight won't be much higher. Clear? On the other side, if this child was having a height age not much affected, but weight is more affected, that is more of a wasted child, the child is emaciated, then what do you think? Malnutrition or a chronic systemic illness. Okay, malnutrition or a chronic systemic illness. Example, a child with a cyanotic congenital heart disease, CVSD child. Because there is always a child is in cardiac failure, so there is negative metabolism, the child is not growing. Okay, a child who is having chronic respiratory infections, chronic asthma, uncontrolled. Most of the time the child is in the hospital, the child is not eating well. What will happen? Again, the child will be having shortness as well as weight will be affected, but more affected will be weight. Okay, so whenever you see a child, when there is height is more affected, it is either endocrine or syndrome, and when weight is more affected, it is either malnutrition or a chronic systemic illness. Clear? That is okay. Then you should know about two problems where the shortness is normal. It is called a physiological shortness. Can anybody say what is physiological short stature? Familial short stature. Very good. Familial short stature. Familial short stature means the child is short, the parents are also short. Okay, parents are also short. If in this graph, what is telling about against the diagnosis of familial short stature? You are right. Yes.
The ring.
Mid-parallel height is?
Where is the arrow?
Okay. Okay. You know about mid-parallel height? Not very familiar. Mid-parallel. Okay. 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 The formula for mid-parallel height is father's height plus mother's height plus 30 the whole divided by 2 for a boy and for a girl minus 30 whole. Why those differences there? Why what is this 30? In all ethnic communities, men are 12 to 15 centimeter taller because estrogen. Okay, so they are taller. So even in our chart, actually, if you look at the 50th percentile in the girls at 18 years is 158 centimeters, and 50th percentile for the boys that is 170 centimeters. So there is a small difference of 12 centimeters. So that is why we are getting this ratio. Okay. So this mid-parallel height, where will you plot? You will plot it at the 18-year line. This is the 18-year line. Okay, this is the 18-year line. So in the 18-year line, you will be plotted.
Can you see the arrow? Red arrow? Up there.
You can see that.
Red arrow.
You can see that now. No? Very clear. Okay. So this is how you plot it. Okay, when you are plotting it like this, see it is between which lines? 10th percentile line and the 25th percentile line. Okay. So that tells us potential for this child is between 10th and 25th. And it is exactly at some height will be there. And from there, you will be adding or subtracting 6 centimeters. That is what is called a mid-parallel height range. Okay, because even though father and mother has a particular height, and you are calculating the mid-parallel height, then again the child can deviate a little this side or that side. No, for all human parameters it is like that. It won't be never be one particular. There is a range for everything. For hemoglobin B range like that, no? So from mid-parallel height also you calculate the mid-parallel height, then plus or minus 6 centimeters. This plus or minus 6 centimeters for everyone, for boy and girl. Clear? Okay. So if the child is in that particular range, then you will tell that the child is having familial short stretch. Okay. If the child is not in that particular, that is the mid-parallel height when you plot it is just below the third centimeter. Okay, that means both parents are short and the child is also short. Then you think it is a familial short stretch. But mid-parallel height is in the 10th and the 25th centimeter, and the child is below the third centimeter, means it is some problem you need to do. Clear? Then what is this? What is the name of this thing? There is a ladder like thing. Have you seen this in the glow chart? This is called a mid-parallel height calculator. Mid-parallel height calculator. Here, there is no need of doing any calculation. Okay, you need not add 13 or anything. You just join here the height of the father is 162. And height of the mother is 154. You are joining these two numbers and you see that the child's mid-parallel height is between 10 and 15. Okay, so it is very easy to find out what is the mid-parallel centimeter. Okay, so this is called a mid-parallel height calculator. Then there is another part in here. Okay. This is an inset in the graph. Okay, there is a box. You can see that. Okay, what is that box about? That is a easy reference to find out which child is having obesity, which child is having overweight. That is all. We are not calculating any BMI or anything. Okay. See, in the x-axis there is height in centimeters. See here, there is height in centimeter and there is weight in kg. Only thing is, we usually less than 5 years and all we cannot use this chart. But more than that, we can very easily find out.
8 years. 8 years.
8 years. Yes. And if it is 140 centimeter, the height is 140 centimeter and the weight is 40. Can anyone say where does the child fall? Height is 140 and weight is 140 and weight is 40. Yes? Overweight. Very good. Overweight. See, there is a black line. Between the black line and the yellow line, this is the normal weight range. Okay. Between that yellow line and red line, it is overweight. Above that red line, it is obesity. Okay. So this is how you use the growth chart. Then, when should you measure? When should you measure? That's a very, very important point. When is the time for measure? Okay. So, when you are measuring children to find out short stature, you need to continuously measure. So, when you measure, you have to measure at the time of birth, then at 6 weeks, 14 weeks, then and after measurement you have to plot it in the growth chart. And this what all you should measure, weight, length and head circumference should be measured. And after 1.5 years it is like every 6 months you can monitor up to 5 years, and after that if there is no problem up to 18 years yearly monitoring is enough. Okay. Then when you are monitoring the child, what all will you find? You will be seeing what is the height velocity of the child. Height velocity. So height velocity is the most important factor in identifying a problem in growth. Okay, because as we know there are 7 lines from 3rd centile to 97th centile. Everyone is normal. Isn't it? When a child is growing in the 90th centile, the child will grow from 3 years to maybe 16 years or 17 years in the 3rd centile. Otherwise 90th centile, 90th centile. All are normal. But if there is a fall in velocity, that is good. That is why the growth velocity is important. What do you mean by crossing of centile? Crossing of centile means when a child was very young, the child was in the 90th centile. Suppose after 2 years when you are seeing the child, you are seeing the child is in the 75th centile. Then the child is crossing again. So once the child crosses 2 important lines, that means there is a growth problem. In such children, we don't wait till the child goes to the 3rd centile. We should intervene very early. Okay. Once in the endocrine clinic, a child came with short stature. Actually, it was not short stature. Mother was telling, my child is not growing well. So when I plotted, the child was actually between 3rd and 10th centile. Okay. So I explained to the mother, see, your child is not short, it is normal. Mid-panel height was a little level. But then the mother told, no, I have previous recordings. Then I plotted all the recordings. I was seeing that there is a drop in the centimeters. And when we did a MRI, there was a tumor in the brain. There was no other symptom. The only symptom was the child was normal. That is the importance of plotting a growth chart. So this is another chart other than the growth chart. This is called a growth velocity chart. Growth velocity chart. Okay. Here we told the important line is the which line? In this chart, which is the important line? The 3rd centile. Okay. here the important line is actually the 25th centimeter. 25th centimeter. So just remember that. You need not know it very detailedly, but you should know that a height velocity chart, if the height velocity is less than 25th centimeter, then it is abnormal. Okay, this is also available at the net. And when you are looking at the velocity, you will find out all types of growth abnormalities. So the growth abnormality can be due to malnutrition, it can be due to hormone problems, or it can be due to the normal type of short stature. One is due to familial short stature. There is one more. What is that? Constitution delayed growth and what is constitution delayed growth and the word? Yes. Yes. In constitution delayed growth and puberty, what happens is the child is born normally. We know that every child, even without looking at the height of the baby, the height and weight of the mother or father, if the mother is being cared for properly, at the time of birth, everyone is same. Okay. But in constitution delayed growth and puberty, what happens is after some day there is a catch down. There is a catch down, and the child will grow just below the third centimeter. Just below the third centimeter. And it will grow, and grow, but always the child will be one of the smallest. But at the time of puberty, when all the other children are having the growth spurt, this child will remain short again. That will be the time we will identify the child is very short. Okay, and you also will know, you also will remember one child, one friend of yours, or maybe one of you who was not growing in the school when all the others were. Okay, and you are meeting that particular person after 5 years in the Indian medicals or so, and you will see that, oh, you have grown. Okay, that is what is called constitution delayed growth. Finally, they end up in the normal cell. The only thing is there is a delay in growth. There is a delay in growth and there is a delay. That is constitution delayed growth. Okay. So, having said this, how will you differentiate? So, for differentiating, actually, you need to look at all those things. I told you, one, you have identified a subset where the height is more affected than weight. Okay, you have told it could be an endocrine cause or a syndromic cause. There is another subset where weight is more affected, you call it a malnutrition cause. Okay, another point when we are going to see this short children, we will be looking at the bone age. Bone age. Bone age means the X-ray of the hand actually. X-ray of the hand. When you are looking at the X-ray of the hand, you will look at the size and shape of the interfaces of few bones, like the radius, the first metacarpal, and all the phalanx. And there are charts, there are photos which can match with each age. Okay, and doing that you will identify the bones. Okay, so now we have identified height age, weight age, and bone age. When there is a bone age delay, maximum bone age delay occurs with the endocrine conditions. Okay, maximum bone age delay occurs with the endocrine condition. And out of the endocrine condition, thyroid disorders is the one with the maximum bone age delay. Then comes growth hormone deficiency. Okay, will there be delay in bone age and malnutrition? Yes, because when the nutrients are less, the bones will be not formed well, the epiphysis won't be good. So there will be delay in malnutrition also, but that will be to the tune of maybe 1 or 2 years. Okay, in familial short stature, there is no bone age. Okay, familial short stature, no bone age. Constitution delayed growth and puberty, there is some bone age. That means maybe 2 to 3 years maximum. You can remember 2 years. Okay, and always remember if there is a bone age delay of more than 3 years, it is always perfect. it cannot be a normal. There is a problem. Okay. So with the height age, weight age and bone age, you can get an idea of what is happening. Then only we embark on the blood test. Okay. Which test we will do for identifying a problem with growth? Anybody? You are given a case, a short case in the exam, and the examiner is asking which all test you will do. Yes? The first test should be thyroid, okay, but even before that you have to do a hemoglobin. Okay, hemoglobin is very, very important because hemoglobin will tell you whether there is anemia, because chronic anemia itself can affect your growth. Then you can also do an ESR, isn't it? Because ESR will tell us whether there is a chronic infection. So a CBC, that is complete blood count will identify these problems. I still remember madam presenting a case of chronic anemia with severe short stature, and with iron the child had without any other intervention child had. So that is good. Then comes your thyroid. Okay, thyroid for all short children we should do a thyroid profile, and when you are doing a thyroid profile, remember it is T4 anti-acid, it is not T3. Always do a T4 anti-acid. T3 doesn't have much role in identifying hypertension. This T4 anti-acid. Then a calcium profile, calcium, phosphorus and alkaline phosphates, because we need to look at the bone health. Then one creatinine is very important, because your kidney disease, chronic kidney disease can just present with short stature and anemia. Nobody will know. If you look at the blood pressure, you will see elevated blood pressure. But for children, we may not look at it. Okay? So it is very important to look for creatinine. Okay. Then you may do some other tests like your function test and things like that. And always remember, in a short girl, always think about Turner syndrome. Turner syndrome. Have you heard of Turner syndrome? Turner syndrome. Can anyone say what is Turner syndrome? This is a chromosomal disorder. Yes. 45? X. What is the disorder? Monosomy of the X is there. And there are some features. What are they? Short stature, wet neck, low hair, then rectus excavator, then shield leg chest, wide space nipples. Okay, short for metacarpal, even slow medicine. But there can be girl child who is coming with short stature. When you are not getting anything in the initial test, it is always better to do it. Okay. So after eliminating all these conditions, only we should think about a growth hormone deficiency. Okay. For growth hormone deficiency also, never advise a single growth hormone test. It is not useful because growth hormone is a pulsatility. Okay. So for that we have to admit that you have to do a growth hormone assay by stimulating, and then you have to take multiple blood samples and do it. So the message is actually, whenever you see a short child, you have to think about common things. 60%, always remember, 60% of all children born with short stature are having either familial short stature or constant. And out of the rest 40%, 25% will be having some other problem, some nutrition problem, some systemic illness. Only 15% will be having an endocrine. And a vast majority of it will be diabetes, which any doctor can. Okay. I think that is the end of the lecture.
What is the bone age? Go back and they should, PG should know what is the clue.
Yes. Okay.
The bone age is?
Anyone? You make a guess. It is okay. Can you know?
Roughly?
It's 2 years actually. It's 2 years. Okay.
And he is 8-year-old. So
Yes,
the
8
difference
years.
is?
6 years.
6 years old. More likely to be
Pardon? Endocrine.
endocrine. I'm looking at him, it's endocrine. അവന്റെ പടം കാണിക്കും. You should spot that. That's a spotter actually, isn't it?
Yes. Yes.
Look at him.
There is some.
And put his features also. He is not mentally subnormal. He doesn't look like a hypothyroid. And some features.
There's a prominence of the forehead.
No. That same thing, same slide had. I think I want all the people to. First slide. Full length.
Yes.
Again, press. Yeah, this one. His dresses are not getting small. His teeth are not falling. Some teeth abnormality. And look at his face.
There is some mid-face smallness, no? Mid-facial hypoplasm is there. There is prominent forehead.
Yeah.
You're right. Louder.
Child-like, very
Hypothalamus.
child. Doesn't look like an 8-year-old child. We call them angel face or cherubic face. Look at his cheeks. The clue is there.
See, looking at the child itself, we will have not many ideas. See, for this particular child, actually, after 1 year, the growth was like this. There was no growth at all. Then we identified that if the posterior center, what test you will do, we can just discuss that as it. Okay. If you are suspecting a growth hormone deficiency, like what Madam told, the height is low and the body height is low, then what are the tests you do after doing the basic things? Okay, even before that, any other marker for your growth hormone axis? IGF-1 and IGF-BP3. IGF-1 and IGF-BP3. When we are discussing IGF-1, we should always remember IGF-1 is not very useful in very young children. IGF-1 will be less in malnutrition. So more specific is actually IGF-BP3, but it is more costly. Then we will go for a growth hormone stimulation test. Okay. So which are the agents which we use for growth hormone stimulation? Insulin is correct. But practically, we all are very much afraid of insulin because insulin will produce
is prone for what?
severe hypoglycemia.
Hypoglycemia. We are already prone for hypoglycemia. So we
don't use practically. It's there in the textbook, but most of us don't use. You are right. Then what else? Some other few more agents for stimulation.
You said yes.
Glucagon, arginine. Okay, and the normal one which we use is clonidine. So why are we admitting children for growth hormone deficiency? Why can't we tell them we go to a lab and take? It should be early morning. Okay, that is good. But when we are using clonidine, what can? There can be orthostatic hypotension. So we should tell the parent there is a chance the child can develop hypotension. We should keep a IV line which is padded. We should keep one saline bolus ready, and then we should give the tablet in the morning, early morning after a fasting. Because why are we doing all this? Sleep is a stimulus for growth hormone. Okay, then fasting is a stimulus for growth hormone. So when we are doing this, there are physiological stimulus also. That's why we are doing it in the morning. And what is the dose? Okay, it's actually 150 microgram per liter square. And we should give it before, after taking a BP and all. Then, how many samples? See, our idea is growth there are pulses. Okay. Usually these pulses are at 20 minutes interval, 30 minutes interval, something like that. So what we do is we take 5 consecutive cycles so that we catch either of one of these spikes. And if you are getting a single value out of these 5 samples, if you are getting one value more than 7, you are ruling out growth hormones. Okay, it is not actually a diagnosis, it is a ruling out of growth hormones. Okay, that is why it is not a gold standard test. So that is why we should not do it in every child. You should actually select the patient properly. When a child is not growing, we look at the child for some time. The height velocity is very poor. Like Madam told, the bone age is very much delayed. Okay, there is no other reason. Then you think about thyroid, cortisol, and for postparents, always remember, before embarking on a growth hormone test, you should make sure the thyroid and cortisol levels are normal. Why? Anybody? Why? Because cortisol as well as thyroxine are needed for the synthesis and release of growth hormone. Okay. So when you are seeing a child who is having hypopituitarism, what you will treat first? You have to, no, even before thyroid you have to supplement cortisol. Why? Because when you supplement thyroxine, the metabolic rate will increase. So the child will become more prone for an adrenal crisis. So first you give hydrocortisone, then after a few days you start with thyroxine, and once the thyroxine level has normalized, you go for that. Okay. And what about MRI? Should you do MRI in all children or in all children before starting growth hormone? You have to do an MRI. I told you about one child, no? A child who had a tumor. So you have to do, because otherwise you will miss things like that. And your growth hormone will help growing the tumors. Nobody will know. So that's a problem. So you should always do an MRI.
Okay.
Okay.